Mechanics of Ventilation, Part 1 of a Part 5 series. The objectives for this session are to discuss the rationale for why humans breathe, review the mechanics of normal spontaneous breathing, discuss the fundamental components of normal breathing, discuss the mechanics of positive pressure, mechanical ventilation, and introduce 3 broad types of ventilator breaths, and then relate breathing fundamentals to mechanical ventilation. Okay, what's the rationale for humans breathing? Well, the mechanics of ventilation, spontaneous breathing, is as follows. Why do we breathe? Well, we need oxygen to survive. Every cell in our body needs oxygen. We get oxygen by breathing. Why do our cells need oxygen? Well, they need oxygen to make energy. This is called cellular respiration. Without oxygen, our cells don't work. Without working cells, we don't work. Why do we breathe? Additionally, we need to remove carbon dioxide, or CO2, to survive. It's a metabolic waste product. Every cell in our body produces carbon dioxide, CO2. We exhale CO2 only by breathing. Why do we exhale CO2? Well, as I said, CO2 is a waste product of metabolism. Too much CO2 narcosis, and our cells don't work. Without working cells, again, we don't work. What are the normal oxygen and carbon dioxide levels in air? Well, typically, inhaled air consists of approximately 21% oxygen. Exhaled air, after the body uses some oxygen, consists of approximately 16%. When we inhale air, the air contains very little carbon dioxide, 0.04%. However, when we exhale air, we get rid of this waste product, which is approximately 4%. How do we breathe? Let's look at phase 1, inhalation. During inhalation, the lungs expand with air. Oxygen diffuses across the lungs' surface and it enters the bloodstream. Alveolar capillary gas exchange. Phase 2 is exhalation. During exhalation, the lungs expel air and carbon dioxide diffuses across the lung surface, entering the alveoli from the capillaries. So let's look at the mechanics of spontaneous breathing. What's inspiration? When inspiration basically means air goes in. Air is pulled into the airways. How does that happen? Well, it happens because we create a negative pressure within the airways. And as a consequence of that, air moves from a higher pressure, atmospheric, to a lower pressure, which is inside the thorax, inside the lungs, inside the airways. How does that happen? Well, the rib cage expands, the intercostal muscles contract, the diaphragm moves down, and essentially this makes the chest bigger, the thorax gets bigger. And because it gets bigger, within a closed system, which is what the airways are, it creates a negative pressure. And because it creates a negative pressure, air is pulled into the airways, into the lungs, without you even thinking about it. This is all under the control of the respiratory center in the medulla oblongata. How do we expire then? Expiration, what has to happen is the lungs create a positive pressure which is higher than atmospheric pressure, and air is subsequently pushed out. How does this happen? Well, this is passive. This is passive. It just happens when the diaphragm relaxes and moves up. The rib cage gets smaller, the intercostal muscles relax. And as a consequence of that, the lungs recoil passively, creating a positive pressure. By creating a positive pressure, it forces air out into the atmosphere, through the nose and through the mouth. This is called expiration. In spontaneous breathing, the person does all the work of breathing. And when we breathe normally, we don't even think about it. This is something that we do involuntary. Breathing is typically, most of the time, involuntary. However, if we choose to, we can use our voluntary muscles of ventilation or breathing, and we can increase the respiratory rate. We can breathe deeper if we choose to. But typically, this is something we don't even think about. What are some of the fundamental components of normal breathing? Air going in, air going out. Air going in, we said, was inspiration. Air going out was expiration. Other components to think about are normal oxygen saturation. And this is what measures effective ventilation, because we need to get oxygen in and we need to get carbon dioxide out. So what are some of the methods that we can employ to now measure whether ventilation is effective? Well, a non-invasive technique is peripheral pulse oximetry, and we typically refer to it as the SpO2, or the peripheral saturation of oxygen in the blood, arterial blood. And for healthy lungs, an oxygen provided at approximately 21%, normal room air, the SpO2 is typically between 95 and 100%. If we wanted to look at it more invasively, we could do arterial blood gases. And this would measure the SaO2, or the arterial saturation of oxygen in the blood. And for healthy lungs, again, at 21% oxygen, the typical arterial blood gas range for the PaO2 or the SaO2 is 80 to 100 millimeters of mercury, which is the pressure that's created by oxygen in arterial blood. Other considerations are, what are the normal breathing rates? We're talking about the respiratory, or really the ventilatory rates. We refer to it as the respiratory rate, but really what we're doing is ventilating, spontaneous ventilation. Ventilation is just the movement of gas in and out of the lungs. So the normal respiratory rate for an adult at rest is typically 12 to 20 breaths per minute. If we looked at children, well, children breathe faster. They're smaller, their respiratory muscles aren't as developed. So children at rest from 1 birth to 1 year, they breathe at approximately 30 to 60 breaths per minute. From 1 to 3 years of age, approximately 25 to 40 breaths per minute. And from 3 to 6 years of age, approximately 20 to 30 breaths per minute. After which they adhere to the adult range, which is probably going to be between 12 and 20 breaths per minute. Let's look at normal breathing volumes. The term tidal volume, VT or TV, is just an acronym or an abbreviation for tidal volume. Now, tidal volumes, as they indicate, are an amount of gas. Tidal, in and out. So a normal tidal volume or tidal volume is just the air or the amount of air that moves in and out during normal breathing or normal inspiration and expiration or normal inhalation and exhalation. Typically, not normally, but typically, adults have a tidal volume of approximately 500 mils per breath. We're all different. Some have got a big chest, some have got a small chest. Some have got increased metabolic requirements, some have got decreased metabolic requirements. But typically, the formula for working out tidal volume, or the amount of air that moves in and out of the chest with each breath, is about 5 to 7 mils per kg of body mass. In children, it's about 5 to 7 mils per kg as well for an ideal body weight. And that means when we're talking about ideal for both adults and children, we're talking about what they would normally be according to their percentiles, according to their age. Not obese, not emaciated, not morbidly obese, normal. However, tidal volume is not a parameter that is typically used for pediatric mechanical ventilation, unless they're older. But tidal volume still is the volume of gas that is inhaled and exhaled during normal, spontaneous breathing. And typically, as we said, it's about 5 to 7 mils per kg. Let's look at some other volumes. Minute ventilation volumes. Well, minute ventilation is the amount of air the person moves in and out in 1 minute. And simply, it's ventilation rate or the breathing rate multiplied by the total volume. And the rationale for minute ventilation is to eliminate CO2 or carbon dioxide. Because if your minute ventilation is too fast or too big or too great, greater than normal, you will remove too much carbon dioxide, and this can affect you physiologically. However, by the other token, if you hypoventilate, or you're bradypneic, or your combination of both bradypneic and hypoventilate, you won't eliminate CO2 and it will accumulate. And this can cause a CO2 narcosis. So typically, the minute ventilation volumes in an adult are about 5 to 8 litres per minute. In children, they're smaller, so we're looking at really 5 to 7 mils per kg for an ideal body weight. Take that tidal volume and multiply it by the breathing rate. Let's look at breathing times, which are referred to as the breathing ratio, the inspiration-expiration ratio, or the IE ratio. Now, under normal circumstances, normal people have more time available for themselves to expire gas or air. This is called the expiratory time. And typically, it's twice as long as the inspiratory time. So the IE ratio, typically, in a normal person, is about 1 to 2. And just read exactly as that, as 1 to 2. And the physiological rationale for this is, you don't want to breathe in before you've exhaled completely, because this would cause too much gas to accumulate in your airways and your lungs and potentially result in overinflation of your lungs. So the physiological rationale for an IE ratio of 1 to 2 is to provide the person with time to exhale before they inhale for the next breath. Make sure that you've breathed out adequate amount of air before you breathe in again. The normal IE ratio is typically 1 to 2 or 1 to 3. Let's look at the spontaneous breathing waveform. It's a graphical representation of inspiration and expiration, and it's measuring the pressure within the airways, which can be positive and it can be negative, and it's measured in centimetres of water. During inspiration, we said the diaphragm moves down, the intercostal muscles contract, the thorax moves out, the chest becomes bigger. This creates a negative pressure, which is represented by the I below the zero baseline. Gas moves into the lungs. When the gas has reached its limit, controlled by the respiratory centre in the medulla oblongata in the brain, inspiration stops. The diaphragm relaxes, the intercostal muscles relax, the chest wall goes back into its pre-inspiratory position. This creates a positive pressure, represented by the E going above the zero baseline. So during inspiration, the pressure is negative. During expiration, the pressure is positive. Then, between the waveforms, there's a pause, because we've got to allow time for gas to be exhaled. And this determines the IE ratio in time. Now let's review the mechanics of positive pressure, mechanical ventilation. The mechanics of breathing using positive pressure mechanical ventilation. These are the sorts of patients that we're talking about, because most patients that are intubated and ventilated will be in some sort of acute care setting, such as a critical care unit, an intensive care, a cardiac care unit, a triage area or an emergency and trauma department, a pediatric ICU, a neonatal ICU, all critical care areas. Mechanical ventilation. Why do we need mechanical ventilation? Well, mechanical ventilation is used when a person cannot breathe effectively, which occurs in brain or spinal cord injuries or disease, disorders of the muscles such as poliomyelitis or a motor neurone disorder or disease, muscular dystrophies, lung disorders such as chronic obstructive pulmonary disease, asthma, chronic bronchitis, bronchiectasis, emphysema, interstitial or fibrotic lung disease, the list goes on. Or it can be used for sleep disorders, such as sleep apnea, which is going to be non-invasive, using nasal prongs, a partial mask, or a full mask. Mechanical ventilation, why do we need it? Well, when we don't want the patient to breathe. For example, during operations, such as a general anaesthesia, heart surgery, thoracic surgery, neurosurgery, etc. Or we want to minimise metabolic demands, decrease the work of breathing, decrease myocardial oxygen demands, such as in heart failure. Or we want to control how much oxygen or carbon dioxide a patient gets in intracranial issues such as an elevated intracranial pressure, or within a neurosurgical ICU, but primarily to control intracranial pressure. Let's look at the mechanics of breathing using positive pressure mechanical ventilation, and we'll have a comparison now to normal spontaneous breathing. With inspiration, as we said, in a spontaneously breathing person, the rib cage expands passively, the diaphragm moves down passively, and air goes in from a higher pressure to a lower pressure passively. This is normal spontaneous inspiration or inhalation. When we have mechanical ventilation, air is pushed in. This is forceful. This is positive pressure. So it's forced in to the airways using positive pressure, and as a consequence of that, the diaphragm is forced down. The lungs are forced to inflate, and the thorax gets bigger. With expiration during mechanical ventilation, this is passive. So basically it's the same as when we have spontaneous breathing. The lungs relax, recoil, diaphragm relaxes, recoils. This creates a positive pressure, and air is pushed out passively as the thorax gets smaller. Identical to what happens with normal spontaneous breathing. But time has to be allowed for expiration, which is why the machine will not breathe in again for the patient until they've exhaled. I ratio 1:2. So let's look at the mechanics of mechanical breathing. The machine does all the work most of the time. The machine does the work of breathing. The patient typically does nothing. There are 3 broad types of mechanical ventilator breaths, which we'll review now. There's control, assisted, and supported. These are 3 broad types of ventilator breaths. Control, think of the term. Control means the machine is in control. It's mandatory. So the machine does all the work of breathing, 100%. If it's assisted, the ventilator typically only assists with a little bit and still does 95% of the work. The patient can sort of be involved about 5%. Supported means the patient's doing most of the work. The ventilator only assists when required to do so. However, this depends on the mode of ventilation, which we'll be discussing in other parts of this course. The ventilator in supported breathing assists with a minimal amount of breathing, let's just say approximately 10%. Let's review some of the breathing fundamentals which we looked at with spontaneous breathing and relate them to mechanical ventilation. We still have an oxygen saturation, and patients who are on mechanical ventilation require continuous pulse oximetry, which is measured peripherally in the SpO2. And they typically get an oxygen percentage of around about 21 to 100%, depending on their condition. And the optimal range that we want to aim for when we're measuring the effectiveness of oxygenation is a range between 95 to 99%. 100% may not give us the information that we want. We may be providing too much oxygen in that situation. So the optimal range is considered to be 95 to 99%. Arterial blood gases for mechanical ventilation is mandatory for an FiO2 of around about 21 to 100%, and the optimal range for the PaO2, or the partial pressure of oxygen, is 80 to 100 millimeters of mercury. Typical breathing rates when on a mechanical ventilator are controversial. However, if we're following spontaneous breathing patterns, in an adult we're aiming still between 12 and 20 breaths per minute. In children from birth to 1 year, 30 to 60 breaths per minute. From 1 to 3 years, 25 to 40 breaths per minute. From 3 to 6 years, 20 to 30 breaths per minute. However, the rate is determined by looking at them, air entry, chest expansion. The rate is also determined by the PaCO2 from the arterial blood gas, which the optimal range is between 35 and 45 millimeters of mercury, unless the intensivist determines that permissive hypoxia or permissive hypercarbia is acceptable. We can also, as we indicated previously, consider the minute ventilation, because we don't want to hyperventilate and we don't want to hypoventilate. Typical breathing volumes in an adult, as we indicated earlier, are about 500 mils per breath. However, adults are all not the same, so we have a typical range of around about 5 to 7 mils per kg of body mass. If you weigh 70 kilos, for example, and you use the 5 sevens are 35, so you're looking at 350 mils per breath. If you're looking at 7 by 7, you're looking at 7 sevens are 49, 500 mils per kg of body mass. Children typically don't use tidal volumes unless they're older. They use pressure. But if the children are old enough, then typically they go for 5 to 7 mils per kg of the ideal body weight. But as I indicated, normally tidal volume is not a parameter or measurement that's used for pediatric ventilation. Pressure in centimeters of water is. Looking at chest expansion is. Looking at chest X-ray and chest expansion is. Looking at normal arterial blood gases, the PaCO2 is. Looking at minute volume ventilations is. Typical minute ventilation volumes, as I indicated previously, in spontaneous, this is a parameter that we look at with mechanical ventilation. In an adult, the objective is 5 to 8 litres per minute with normal PaCO2 from the arterial blood gas. In children, 5 to 7 mils per kg of ideal body weight, multiplying the tidal volume by the reading rate will give us the minute ventilation volumes. But minute ventilation is determined by arterial blood gas analysis, the PaCO2. And the optimal range, as we indicated previously, is about 35 to 45 millimeters of mercury. Let's aim for a mean of 40 millimeters of mercury. So in a ventilated patient, mechanically ventilated patient, typical IU ratios are simulated as we would with normal spontaneous breathing. So the inspiration-expiration time is replicated in 1 to 2, meaning the ventilator allows twice as long for expiration as it takes for inspiration. 1 to 2. So, just to conclude, when we look at specific breathing waveforms for this section, there are typically 4 that we're looking at. Volume control, which means a specific tidal volume has been set and delivered at a certain rate. Pressure control, a certain pressure has been set, delivered at a certain rate. Pressure support, which just allows the patient to breathe spontaneously with whatever support is required to assist their breathing. Assist control, a set tidal volume or pressure has been set with a set tidal volume and breathing rate. However, if the patient chooses to, they can tell the machine that they want to have a breathing rate that is a little bit faster. They determine the breathing rate, within limits, of course. So the take-home message is, for this course, healthcare providers, you, whether you're a physician, whether you're a nurse, whether you're a respiratory therapist, have to make sure that when you look after a patient who's on a mechanical ventilator, sure, remember the science, but there's always an element of caring that is associated with it. So the take-home message is, healthcare providers must ensure that the caring is always in the science. Thank you. Check out part 2 now, and other Dr. Manny Learn Shops on YouTube.